Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series, brought to you in part by a grant from the Iowa Oncology Society. And tonight we're going to be talking about palliative care with my friend and colleague, Dr. Karan Soni. Welcome, Dr. Soni.
Thank you very much, Dr. Deming. Glad to be here.
So Dr. Soni is one of my newest colleagues, having arrived at MercyOne just about 2 months ago?
Pretty much. Started out in September, so
In September, yeah.
fresh recruit.
So we've had great weather. You haven't got to experience any of our snow yet, but that's coming.
I'm glad to have it that way.
So Dr. Soni did an internal medicine residency, and then from residency went on to a fellowship in hospice and palliative care at Geisinger Clinic in Pennsylvania. And then, as I said, just joined us in September. So tell us a bit about you. How did you decide to become a doctor to begin with?
Absolutely. So ever since I was 5, I always had this dream of following in my dad's footsteps. He's a pediatrician. And that was me in Kuwait. That's where I spent most of my childhood. Fast forwarding through to high school, that's what I ended up, pursuing. I got into medical school in India. So I was in Christian Medical College in Punjab. Did 5.5 to 6 years over there. And ended up pursuing internal medicine. I did my residency out in Florida, in Orlando. From there, I learned about palliative medicine, really only through residency, not so much of an experience for that available in India. It's a relatively newer field and it's still growing, and the rest of the world is catching up.
Mm-hmm.
So I pursued my fellowship out in Geisinger in Danville, and managed to cross paths with the beautiful people here. This was the first place that I interviewed in, and we pretty much signed on pretty quickly.
Yeah.
So excited to be here.
So tell me, growing up with your dad as a pediatrician, was he your doctor? And as a kid, did you get to go into the office and help do stuff, filing or other things?
Yeah, it's funny you bring that up. So I was the experimental kid for them with all the milestone testing. Oh, he's going to catch this milestone. All the pediatricians, they're all about that. So they used to check which milestones, he's catching up with. And he said I was pretty much the guinea pig for some of the things they were trying out. So that was at home. I did get to go to the hospital with him quite a few times. In particular, I remember there was this gaming room in the hospital they had for a lot of the kids that they would see, kids with illnesses around there. So it was nice to drop by sometimes. I only went there maybe twice or thrice, but those are vague memories I have still from childhood.
And do you have brothers and sisters, and did any of them go into medicine?
So I have one elder brother. He's 8 years older than me. He went into engineering. He's an IT guy. He's still in Florida. He's been there for quite a few years now.
So internship in internal medicine. So you do a little bit of everything during that residency. You learn about cardiology and oncology and gastroenterology and pretty much everything. And then at what point were you exposed to palliative care as a fellowship specialty?
That's an excellent question. It wasn't a very formal introduction, I would say. So my internal medicine residency was essentially rotating between 2 hospitals, between my community hospital and the VA in Orlando. So the VA, we did have a palliative medicine team and a hospice facility attached to the VA hospital. So we did get formal rotations through that, which I mainly had in 3rd year. Most of the people in our residency had it between 2nd and 3rd years. But I feel like my introduction was before that, even starting out as an intern. This was pretty much the winter when COVID first came into the picture. And we had so many patients locked in the ICUs in isolation, and a lot of people who couldn't be with their families through crisis situations in those times. One patient in particular that I remember was this lady, this South Indian lady who was admitted to the ICU with bad COVID pneumonia. We were taking care of her. We tried getting through to family members. The only contact we had was a daughter in New York. So essentially, all I could do was give her the summaries, give her the updates, everything that we're trying. Um, and it was a time of chaos where we were just learning what to
Mm-hmm.
do. What's remdesivir? What's tocilizumab? All those medications coming up. What lab should we do? Kind of learning through those things. I tried to get in contact with her. She got me connected with a cousin who's a doctor. So explaining through to all that, they were kind of very appreciative of getting that information
Mm-hmm.
because it was hard. And sometimes all it takes is a phone call,
Mm-hmm.
letting family
Mm-hmm.
members know what's going on. Going through those experiences, seeing patients like that, and then learning it as part of the formal curriculum, that is essentially a lot of what it is. It's supportive in nature. It's meant to help the patients, their families, get through situations the best way we can.
Yeah.
Fortunately, that lady did recover after a good 3 weeks in the ICU, so that turned out to be a happy ending. But
Yeah. So, my observation. So, I've never done a formal training program in palliative care. I'm a radiation oncologist, but taking care of many, many, many cancer patients. But I sort of see palliative care as kind of this cross between being a doctor, a social worker, a minister, and a therapist.
I think you're right. I've been feeling more and more every day that I do this too. And it's a big part of this. That's why, our team works so much more with our interdisciplinary groups for patients for this, with social workers. We're highly integrated with them. My team here has a social worker as part of our daily rounds. We're working closer with chaplaincy. We never did these things a lot through general internal medicine, and
Hmm.
only so much that hospitalists might be going through this that I can imagine.
Yeah. I would throw one more profession into the mix, and that would be a philosopher. I think a lot of what we do in taking care of patients with advanced and metastatic cancer is philosophical. How do you find joy today, knowing that you're living with a disease process that over time, and maybe it's years from now, is likely to result in your death?
That's true. And it's difficult, and it's not easy for everyone to come in terms with. There are people who are able to go through those experiences. There are people who are great at handling those situations, going through them, but it takes a lot of a toll on them. And I've seen, similar residents who maybe were great at, that kind of situation, helping families through it, but some people aren't able to do that as frequently or as often.
Mm-hmm.
Um, and it's not the easiest thing to do, but one of the things that really helped me was the connection that I was able to build with a lot of the patients I was seeing for this. It Through my fellowship, I realized that I've never been able to have such open conversations with my patients, actually get to know them as a person, see what they're going through. And I think at the end of the day, that's what helped me to help them in the
Mm-hmm.
best way possible, them, their families. That connection was hard to do because you don't get that much time to spend on a
Yes,
regular
yes.
basis.
And you're fairly young and new in this, so I think just from my own experience uh of being comfortable, truly comfortable sitting with families and patients where the discussion of death and finding joy and meaning and purpose became natural, and certainly not something I learned in medical school or residency, but comes through, I think, experience with being open to having those conversations with patients.
I absolutely agree with that sentiment. You have to go in as open minded as possible because you never know what outlook you know the, the person will have, their family is going to have. And at the end of the day, the main focus I try to have in mind is, no matter what's going on, helping them live the best way they can through it. That's what I try to achieve with everyone I'm seeing, and I think that's what really helps me day to day.
Yes, yeah, I would say that's too. There's I didn't come up with this, but I repeat it many times. Not every patient can be cured, but every patient can be healed. And how do we do healing? So before we talk more about that, let me just have you explain to everyone, what is palliative medicine? So it's a new specialty. It's probably one of the newest that we have. And as we said, it's a fellowship. So you have to have done a residency in something, either internal medicine or family medicine or maybe oncology.
An
Yeah, or
emergency group.
emergency. Yeah. So tell us, how would you define palliative medicine?
Absolutely. So that's often what I end up having to do with every single
With
new
every
patient I'm
patient,
being.
like, why am I here?
And it helps them know what's going on. So the simplest way to get it across is simplest way to introduce it is it is supportive medicine in the broadest aspect that you can picture that. It is in the context of advanced illnesses or terminal conditions. So generally the patients would have either a cancer diagnosis or advanced heart, lung, kidney diseases along that line. So it's a specialty that's dealing with supportive care for that patient population in any way possible. It ends up being in two broad ways that we eventually help. One being with symptom management. So that can be with, say, uncontrolled difficulty breathing, nausea, pain, things like that, that we can help with. Often at times, patients in that situation have multiple medical teams treating them, yet there are these basic issues which aren't optimally controlled, maybe very out of control in some situations. So we try to get everyone's heads in together, see what we can explore to do it. Medication wise, that's fine, but explore any other procedure that could help, or non pharmacological treatment that can help, which includes a broad aspect of options we have, a lot of which uh, I love that are available in your clinic too,
Yeah,
Dr.
what we're
Arun.
doing, the integrative approaches with acupuncture, chiropractic, massage, osteopathic manipulation. So as you pointed out, the patients that by definition, they've got some advanced disease, and it maybe is cancer, but it also might be advanced heart disease, advanced COPD, lung disease, dementia that's advanced, or stroke. So all of those doctors will have a specialist who is kind of in charge of their disease. Like if they've got advanced heart disease, they've all got a cardiologist. If they've got advanced lung disease or COPD, emphysema, they've got a lung doctor. So you're not brought on to be the primary manager of the disease they have, but as you said, the supportive person to help manage the symptoms and also bring on board all of those supportive services. So you probably have within your palliative medicine clinic and department many other folks besides a palliative care doctor who is on your team. What are some of your other team members that you have?
Absolutely. So currently in my team, uh, there's me, there's practitioners we have nurse navigators, both on the clinic side as well as in the inpatient side, to really help coordinate with a lot of different teams that we often have to. We have a social worker in our team currently, and our team is still very growing and new. It's in a structuring process, but there are teams with a lot of we used to have a chaplain on the team too, so that's something we're looking to build up in our team at present. Um, and Therapists can be part of the team too. There are different departments and teams out there with more of the integrative aspect, so they can have therapists as part of their team, and the scope of the team can vary too. A lot of teams have a home-based approaches or home-based teams which are able to go in and provide an extra layer of support. So there's a lot of different ways to do it, and a lot of different ways to practice palliative medicine, really.
Right. And so palliative medicine can be practiced in the inpatient setting where you're not the primary doctor managing the patient, but you're brought on as a consultant. I understand that some larger centers actually have palliative care units within the hospital where the palliative care physician may be actually managing the patient.
Yeah.
And then you've got your clinic where you're seeing outpatients. And then, as you said, some palliative care folks, palliative medicine folks might even go into the home and do home care.
Absolutely, that's right. And that's very important to mention that that's what we are, an extra layer of support who does not replace the primary doctor or the primary specialist who might be treating their conditions. We're there to help with issues that are needing more help in whatever way, shape, or form. A lot of teams are also more integrated with hospice aspects. So sometimes there are teams where the doc might be practicing both palliative medicine as well as be part of their hospice teams. Some of the home-based teams have a combined aspect to them too. In terms of inpatient palliative unit, that is something that my fellowship program used to have. And we essentially had kind of a hybrid part of it where we were working closely with hospice, where if they had inpatient hospice patients in the hospital, our team would be kind of primary for them during that hospitalization.
So we've mentioned several times palliative medicine and we've mentioned hospice. So can you distinguish for us the difference between hospice and palliative medicine or palliative care?
Absolutely. And that's a very common question that gets asked. And unfortunately, a lot of different healthcare workers aren't, very aware of those differences. I'll start by mainly differentiating out what hospice is. Generally speaking, if I could show a Venn diagram, something like a big circle, palliative care tries to support in a lot of different ways, and hospice is essentially a part of it. What hospice tries to do is it's specialized towards end of life care. So, what they try to focus on is comfort focused care, comfort measures towards that end of life. It is a Medicare benefit, and they look at people who would qualify for this having a prognosis or life expectancy of less than 6 months, generally speaking. One of the other things that separates it from the rest of palliative medicine is that they have decided not to pursue any more life prolonging treatments at that point. For example, in cancer patients undergoing chemotherapy with the purpose of prolonging life in that situation. Um, that is one of the big differences that sets it apart. With palliative medicine, there is no such restriction, and that's what we try to do is we hope to get involved earlier so that we can help more earlier. And there's a lot of studies which have shown that early involvement is what makes the difference. Instead of getting us called in for, say, the 10th hospitalization or something like that, which unfortunately happens.
Right. So palliative care, palliative medicine can get involved. Patient may still be going through chemotherapy, radiation therapy, might have, cancer that's treatable, not curable. But today, with the advanced targeted therapies and immunotherapies, many patients with incurable cancer live many years. And so having palliative care being supportive and being part of their team for years, as opposed to hospice where it's 6 months and you've stopped doing anti-cancer treatment and you're really helping to focus on a peaceful death. But whereas palliative care, you're walking alongside them when they're still very functional, very active, and trying to make sure that they're as active and functional as possible, even while they're going through treatment for essentially a disease that's not curable.
Absolutely. That's 100% true and what we strive for, because we're trying to help increase that functionality. We'll try to help you live your best life in no matter what therapies you're going through. So chemotherapies, people have side effects. A lot of it may be illnesses itself. It may be treatments that can affect how a person's living their life. So trying to help through that, understanding that, there are different things that can still happen. There's so much uncertainty in medicine, which makes all these processes difficult. We talk about prognostication, which is determining how much a life expectancy is given, say, here's the patient profile, what do you think? It's important to understand how uncertain all of that is, and that's not an exact science. That number, everyone's subjective valuation of that will be different. You ask 10 different doctors, you'd probably get 10 different answers. um, so we try to help regardless of that situation, what's going on, and just helping live the best life they can.
One thing that I wonder, so, I'm a radiation oncologist my whole professional career, except for a while in the Navy, is been taking care of cancer patients. So when you tell someone that they have cancer that is very treatable but not curable, so that whole phrase, incurable cancer, that comes with this doom and gloom that it's like, um, I don't use the word terminal, but a lot of people jump to that phrase. Whereas someone with congestive heart failure, which is treatable but not curable, doesn't come with that shock value. Or COPD emphysema, you don't cure that. Or type 1 diabetes. I mean, now they probably in general from the time of diagnosis till death maybe have a longer natural history, but they are disease processes that are treatable but not curable. And unless the person gets hit by a truck, it's likely that they are going to die of their congestive heart failure. Is there a difference in because when you practice palliative medicine and you see a congestive heart patient versus a COPD patient versus a patient with stage 4 lung cancer? Do you find that there's this philosophical difference in the way they perceive what their disease process is and how long they are likely to live?
Absolutely, there is. At the core, there always is that difference, and there's a big spectrum of it, because every person is different. Everyone's insight into their disease stage is different. So you never know what that person is thinking or what's going on. Every time I'm seeing a new patient, that's again why it's so important to have an open mind to understand where they're at. And understanding their disease is part of it. With a lot of these non-cancer diagnoses, that spectrum is huge, and a lot of people are still thinking that I've got years to live. I'm going to start playing golf again.
I've got congestive heart failure. I've just been in the hospital, 3 different times over the year, but I get better, and we'll get it under control.
Exactly. And it's those past experiences which also shape a lot of people's outlooks, their perspectives. So understanding all of that is part of it. And that's another reason why it involves a lot of close collaboration with their primary doctors, with their primary specialists who have been treating them over the years. And they are the ones who know the patient best, know their disease best. Working closely with them is a big part of what we do in that situation. Often at times when that specialist or primary doctor is calling us, it's because there's been some sort of drastic change. So walking through that is difficult, and realizing that is extremely hard for many people and their families.
Right. So usually the cardiologist wouldn't get you involved, or the lung doctor wouldn't get you involved unless the patient has started to have some functional deficits because of the symptoms they're experiencing from their heart disease or their lung disease.
Absolutely. And sometimes it's when these changes have gone beyond a point where they're not, say, a surgical candidate or some kind of, or able to, in the specialist view, would be benefit from having, say, repeated angiographies or other invasive testing or procedures.
Or a heart transplant.
Absolutely. Absolutely. Heart transplant, liver transplants. There's certain points beyond which it becomes too risky to be able to do that. Doing that could be much more hurtful. Often at times that's when they call us for guidance and support, and most of the work at that time is understanding where the patient and their families are in their current state, what their expectations are. And unfortunately, sometimes there's a lot of bubble bursting that happens around those situations.
Yeah, they think, oh gosh, I'm on a list to get a heart transplant or on the list to get a liver transplant, and their condition worsens and they're no longer on the list. That has to be disappointing.
Yes, so it is kind of, a lot of it is how to channel that, how to curb that towards better ways to live. And it's a difficult process because these lists are so long. So people may have been having that expectation for years, and then things change, which can happen due to so many reasons. So really, there's such a big spectrum of things that are happening and things that can happen on top of it. Every situation is unique because of that.
Yeah. So we believe in evidence-based medicine, so that showing that bringing palliative medicine onto the team is of value. There was a study that's probably about 12 years old now that was just really shifted the way I thought about palliative medicine. It was the stage 4 lung cancer study, where so stage 4 lung cancer is treatable but not curable. And often when you're initially diagnosed, you'll get treated with chemotherapy and radiation therapy and maybe go through many different cycles. So the study was patients diagnosed with stage 4 lung cancer would either get the normal care they would get with their medical oncologist and radiation oncologist and primary care doctor, or they would get all of that plus a palliative medicine person would be on the team to help with symptom management and sort of this philosophical perspective. And to no one's surprise, the group that had the palliative medicine had better quality of life by every measure. But to most everyone's surprise, the group that had palliative medicine on board also lived statistically longer, had better quality of life, and the cost of their medical care was significantly less than the group that didn't have palliative care. Maybe explain, based on that paper, some of the reasons why the outcomes were so much better by just having palliative medicine on board in addition to all the oncologists.
So it's not a simple thing to explain, right? But that study, did beautifully demonstrate those aspects. Sometimes it's just about having someone able to break down all that complex information that patients may be getting in that situation, in terms of their options, in terms of treatments that are available, in terms of how that disease could affect them, in terms of the complications that they face, the possibilities. A lot of people do significantly better when they have that in mind.
Mm-hmm.
They equip themselves better to be able to deal with it.
Yeah, to really talk about the risks and benefits, because sometimes it's just like, well, give me the next treatment, as opposed to, well, let's talk about
Exactly.
what's this next treatment is not a curative treatment. Here are all the side effects that you might experience, and having more conversations about, do you really want to do this next thing? And part of it is going to be all of these side effects and complications that go with it.
Absolutely. Discussion is what's so important, and unfortunately that needs time. And that's why it's not easy for everyone to be able to be best equipped in that situation. Sometimes it's just having an extra set of eyes, an extra set of layer of support, a team that's evaluating you alongside to say that, okay, you seem to be really doing really well with this, let's keep going. But it also pays homage to the fact that sometimes less is more, and that ends up helping people live better. Sometimes it's unfortunately our medicine is not at that level yet.
Avoiding side effects and complications may have the one of the biggest impacts on quality of life.
It does, and it's impossible to predict who that person is going to be and how that option will turn out for you. So a lot of times we are just essentially experimenting. At that point, we're seeing, whether you're going to follow the majority of the population or what we've seen based on evidence studies, but understanding that nothing is 100% in medicine.
Yeah, it's trial and error, especially, you might be told, well, this has a 30% chance of working. Well, that means a 70% chance that it won't. And, at what point, how good do the odds have to be that you want to give it a try, especially if the consequences can be significant? So we're talking about, as patients where you really need to get to know the patient. So it's certainly different than an urgent care clinic where someone comes in because they think they have strep throat and just want to get a swab and an antibiotic. How do you structure your clinic where you meet with a patient and their family for the very first time? I hope you have more than 15-minute time slots.
Absolutely. So my current clinic, we're doing 60 or 90-minute time slots and 90 minutes for new patients so that we give them all the time they need. A lot of time, the patients or families might not be, you know, it depends if you have 90 minutes to talk about something or 60 minutes and that's it, they might be happy, but we want to give the full opportunity to get to know them and help as much as we can. And a lot of people, there are many people with who have maybe a lot of comorbidities. If there's a lot going on, it does take time getting to know how these things are affecting them. So that's one of the basics where we try to give them as much time as possible. And my introductory meetings are generally that what I try to aim for, both clinic and hospital, but it's definitely much more easier in the clinic. Just getting to know you, know the family, and how you're living with everything. What's quality of life for you? What's a good day? What's an excellent day for them? What's stopping them from doing the things they love? That's basically what I'm trying to figure out too, because that's the only way that it can help tailor, what we do down the road, what we think would be the best thing, and working obviously with their primary doctors, with their specialists in terms of deciding those options.
And you guys have some I'll say tools that so from a pragmatic point of view, there's some things that you help the patient start thinking about and actually preparing for, whether it is what we call advanced directives or a living will, or starting to think about some of those pragmatic things that, even if you've got 5 years left based on averages, it's a good time to start thinking about, getting your affairs in order, having a durable power of attorney, having that. At what point do you start talking about those pragmatic things? Do you do that on day one when you first meet the patient and the family, or when do you start bringing in some of those pragmatic tools that are looking at, even if it's years down the road, the fact that this illness is ultimately going to result in your death?
Absolutely. Great question. It depends. I usually do not try to initiate bringing these tools in that have that aspect of gloom or doom attached to them. I try to avoid any such topics that I can on my initial visit so that we can establish as much of a rapport as possible. I can only help them as much as they're sharing with me and open with me. Sometimes there are patients and families who will bring up those issues they want discussed from the get-go, or maybe that's particularly the kind of assistance they were seeking with. So it depends. In that circumstance, absolutely our team is able to do that, and we dive into whatever they would like help with. And that's where social work, being a part of a team, is extremely helpful, because they specialize in being able to walk them through these documentations. It's not easy, and that's a big thing to understand why talking about death is taboo in our culture, in most cultures, in most religions. It's not something that anyone wants to do. So either the person has that pragmatic mindset from the beginning where they would be open to do it and they appreciate that kind of help from the start. Most people are not.
Right. My financial advisor actually gave me this whole book that wants me to, what songs do I want at my funeral? Who do I want? It's like, I mean, I don't think it's taboo, but I just don't want to do that. But ultimately, if you don't do all of that stuff, somebody's going to have to do it for you. So, but yeah, even someone like me who's not afraid of death, I still don't really want to sit down and put all that stuff to paper yet.
Who wants to be asked that question? I don't think there's anyone who looks forward to a discussion like that. So
Yeah.
that's because we are human, and survival is one of our core instincts.
Mhm.
It's important to understand that.
Yeah. How so now you're here in the middle of the country. Do you think that so Pennsylvania, were you in Western Pennsylvania?
I was in central
Central
Pennsylvania.
Pennsylvania. And would you say that there's similar in terms of outlook as an Iowan in terms of what we would describe as a Midwestern sensibility, or what how would you compare and contrast the population of patients you cared for in central Pennsylvania versus Iowa?
So you'll have to pardon me because I'm still learning
You're
what
still-
that Iowan
Right.
sensibility is.
You've only been there 2 months. So.
but from what I have seen so far, I'm finding a lot of similarities, and it's kind of what helps, I think, anyone deal with the situation is find similarities in situations you are and you've been before and work with that. That being said, there's no real striking differences or cultural differences or things of that nature that I have found yet. I may yet, give me time.
Yeah.
But essentially, I think when it comes to it, it's difficult conversations involved in a lot of these situations, and that doesn't change. So navigating through that is a big challenge, which will always be there in topics like this. So that will be part of it.
Do most patients come with a family member for their initial visit with you?
I think it's a hit or miss. It depends. Um, of course, big part of it being the situation there and the stage of disease there and how much support they're needing. Sometimes patients are really only coming in for their first visit when they already are requiring a lot of support, and they may have caretakers or someone come in with them. We are trying to, we're doing a lot of telehealth visits in the clinic here too. So we're trying to open the possibility, explore how much we can help in that situation. Sometimes, and this is the preferable scenario, when we're getting to know them much earlier, when they're doing everything that they want to, living their best life, a lot of patients come in alone at that time. And generally speaking, I personally don't like diving into those deeper issues or deeper discussions, even regardless of the setting, without a family member present, because it's important for them to know how their families to know how they feel too about these things. So that makes a very important part of these conversations or discussions for sure.
Yeah, it's definitely the whole family going through it, and sometimes it's difficult if the patient is, single, they're widowed or divorced or never married, and they're needing to go from a complete independent lifestyle to having somebody help them. It's always easier if they have a healthy spouse is kind of ideal, or adult children that live nearby that can help. But those that are all alone really do suffer from the lack of caregiving that is done by the family. We don't want to burden the family. I mean, but those patients who don't have someone need to get home care or enrolled in assisted living or a nursing home or hospice if they don't have anyone that can help them.
That's true, and that makes a challenging aspect for many patients, for many situations, when that support structure is limited. And family almost always is the biggest part of anyone's support structure. So it is important to understand that different people's family situations, and the relationships themselves can be quite complicated, which adds another layer to these situations. But generally speaking, family is the biggest part of their support structure, and that's why I believe, certainly, and most of us in my field, that family needs to be involved through these difficult times and in these difficult conversations.
So, Dr. Soni, you say that when you're talking to patients, you're trying to help them figure out, and you might often say, "What does a good day look like for you?" So, let me ask you, as a palliative medicine doctor, what does a good day look like for you from a professional point of view?
That's a tough question, but but a great one regardless. So the sense of fulfillment, I think, being able to help someone who might not have had anyone to listen to them for a long time. Um, there are many situations when that happens, and sometimes it's just the conversation. Sometimes it's just having that ear to listen to, someone to bounce ideas back off, that makes a patient's day. And when I get that kind of encounter, that kind of conversation is really what helps feel like you made a difference. So there will obviously be a lot of situations where it's tough to establish that kind of relationship from the start, but the ones where you do those, and sometimes it can be where you've been in touch with them, with their family for a while, and building through the relationships, but with all the various obstacles that can come into it, mental, emotional, social, um, helping them overcome when sometimes that's achieved, or we kind of, you can sometimes see the sense of burden, the burden off their shoulders being lifted, when these things are discussed at times. Those are some of the most rewarding experiences, I feel, that happens, and most of it is revolving around difficult decision making. Those situations generally are the most, I think, rewarding in
Most
this.
fulfilling, yeah, where you can see fear, anxiety, depression sort of go away, and you'll experience it many, many times that patients or families will just say, "I feel so much better talking to you." I mean, you might not have done anything in terms of changing their medicine or doing anything but it's just this sense of calm and understanding that they have that makes them feel better. And that goes back to kind of this phrase I used at the beginning: not everyone can be cured, but everyone can be healed and get this sense of calm in the midst of what they're going through.
100%. And that's what, more than half the time, that's what makes that biggest difference. And that's what I try to help my patients feel, that this is, we want this to be an ongoing conversation. We want to be able to hold your hand and guide you through these situations as much as you can. And if nothing else, just listen to everything that they have to say. And many a times I spent close to an hour in the room, and we've spoken barely a minute about what's the actual disease, what's really bothering them. We're just talking about a lot of other things. Sometimes that's just what a person needs,
Yeah.
and we're there to help in that way if we can.
And that in and of itself is so rare in this day and age of productivity and RVUs, and how many patients are you going to see for a patient and a family to spend an hour with a doctor is just doesn't happen in most specialties.
I've had some patients tell me that I'm having a doctor sit here and listen to me for how much ever time. It's inconceivable to so many people. And unfortunately, that's the state of our healthcare system, the way it is, the way it's been driven. But I feel like this specialty is a breath of fresh air in that aspect. And, hopefully we can have more and more of that across different specialties, and just learning how to communicate. I think that's actually one of the biggest things I've learned through these experiences is that most of the most of what we do is really communication,
Mm-hmm.
and not just with the patient, their families, their doctors. So much of it is just that communication, and that itself, that alone, can help solve so many things. Uh, It's astounding.
Yes. Let's open it up for questions. We've got a live studio audience here. We also have those of you that are watching us live streaming. If you're watching us live, you can put your question in the comments section. And we've got a microphone here for those of you in the room.
And this question might be more for Dr. Detman. If you've got a patient with stage 4 cancer, do you always refer them for palliative care, whereas someone with incurable cancer?
Yes. So, as an oncologist, I believe strongly that everyone with advanced and metastatic cancer should have palliative care, palliative medicine specialist on the team. Their quality of life will be better, and it's another resource because patients that are living with advanced and metastatic cancer often have many issues, and so having other team members on who can help address the physical, psychosocial, emotional, philosophical, financial, spiritual is a great thing. And fortunately, in our setup now at the MercyOne Richard Deming Cancer Center, we actually have palliative care providers that come into our clinic so that our patients can be seen in our clinic by a palliative care provider. So, but yes, I think it's really important that all of those patients are offered a palliative medicine team member to be on the team.
I'm just putting myself in the role of that patient, and I'm thinking that I would be somebody that might be kind of confused. I would wonder why I'm being referred to palliative care, why I'm a candidate for palliative care. If I'm being referred to hospice, I kind of know what that's about. I mean, I may have a shot, but it's a long shot. If I'm in palliative care, do I have a better shot, so to speak, or is it just the beginning of a process that's going to end in hospice?
You go
Is that
ahead,
for-
Dr. Soni. Yeah.
Absolutely. That's an excellent question too, and a confusion many people in that situation have in our first visits, in our first encounters. And the short answer is, again, it depends in terms of what their situation is, because every situation is unique. Um, Everyone's disease condition has its nuances and its differences. And the biggest thing is the uncertainty with how anyone will respond to said treatment or procedure. It's hard to say, but that's what we can work towards, is giving you that best shot possible in that situation, and the best shot of fighting it. And it could be dealing with different situations, like we were mentioning, physical aspects that it's affecting you, mental, emotional, spiritual. Sometimes when we're tackling those aspects of the overall situation of either the disease or the treatments, how those things are affecting you, that can help increase your chances of getting your best shot. So that's what we try to provide in whatever way we can.
And I would say I understand your question because some patients go, oh,
Yeah.
the doc we've been doing this with my cancer doc for 3 years, and now all of a sudden he says, I'm going to send you to palliative care. This can't be good. So, let me answer that from two perspectives. One, as a cancer doc who is now going to tell my patient, I'm going to bring a palliative medicine specialist onto our team. So, even the words you use, so there are some places that don't use the word palliative care. So they say supportive services. So we're going to bring on a doc who's going to be in charge of all of the supportive services, because we want to bring more services onto your team that will help manage. So I often will start talking about supportive services, but then I'll use the term palliative care because that's what we use, and distinguish is the difference between palliative care and hospice, and that this is an added benefit of another doc who's not in charge of your cancer. You still got your cancer docs, but this will be someone who has more time to address all of the other needs. So it's going to be added benefit, and more of individuals, professionals are going to help you address all of your needs. But it is a conversation that, as I first bring it up, some of the patients are like, whoa, what's going on here that you think I would need to have palliative care? Do you know something I don't know? So part of it is how you present it and how you explain it.
Thank you for mentioning that. And unfortunately, that because everyone is still learning about this, doctors included, everyone in healthcare included, too many times we see patients equating that palliative care introduction to hospice. And the context of that communication or that introduction is what makes all the difference. So really, that's the best way we can help, is if your primary doctor, your primary specialist lays out a clear expectation for you in terms of what aspect we are being brought in to help with. That really makes a huge difference in the way we can help.
Another question.
So if I understand it, the commencement of palliative care isn't initiated by meeting a certain set of criteria. It's just, it can start with diagnosis if the patient is interested in that.
Yes. And in fact, the study we referenced is from the day of your initial diagnosis of an advanced cancer, having a palliative medicine team member on board as one of the professional team will improve quality of life and outcomes. So yes, it doesn't have to, you can be still running 10Ks, lifting weights, and doing everything independently. But if you have an advanced cancer, we know that the expectation is over the next years, there may be a slow, steady decline. So having the teammate on board from day one is better than waiting until the person has progressed to the point that their life expectancy is short. And one of the reasons that people might be suspicious of palliative care is, unfortunately, the American way is not to bring the palliative medicine on early. And so most folks that might know someone who's seen palliative medicine, they didn't get the opportunity to do that till they were close to needing to have hospice care. So we're trying to change that and really utilize these palliative medicine services much earlier in the course of a disease, whether it is advanced metastatic cancer or it is congestive heart failure or COPD or other advanced diseases, chronic kidney disease.
Got a question from a viewer on YouTube. She wants to know, would palliative care be recommended for the colon cancer survivor that is having issues with blockages after surgeries and treatment? It was suggested to check into palliative care by a nurse.
That's an excellent question too. The answer, unfortunately, is not simple, but yes, we are here to provide an extra level of support whatever way we can. And that difficulty could be due to different situations. Maybe they're not getting that adequate support with teams they're currently established with, or not having active cancer is a difficult situation, is a different situation. But our team is there to support in different ways that we can at the ground, at the root of it. So absolutely, we are available to talk through these issues, to see explore the different options we have available in that. So realizing that it is something, it was an advanced illness that person went through, that's really important to realize. And that answer may vary across different palliative providers too, but I believe that we are here to support in every way we can.
Yep, I would definitely say yes. So patients that might be cancer-free but having lots of lingering issues from the chemotherapy, radiation, and surgery, they may have symptoms that are more severe from the treatment than they were from the disease itself. But definitely palliative care can help with symptom management in somebody who has severe symptoms, even if they technically don't have a cancer cell in their body right now.
You mentioned palliative care is relatively new, or some people, it's new to some people. What about the insurers? I mean, are they all on board? Is everybody caught up? I mean, there's no way, if you're getting insurance to cover your cancer, it's going to cover your palliative care also, correct?
Yes, that is almost always the general situation or scenario. And I think most insurers are caught up with this. It is
Yes.
part of the offered services.
And it's the best deal possible because, when you get cancer care, and I'm talking about surgery, chemotherapy, radiation therapy, hugely expensive, all of those procedures. When you sit with a doctor and talk for an hour, extremely cheap and effective, and avoids other costs. So insurance companies are very much understand that having palliative care on the team generally reduces the cost of care. So it is covered by insurance, and it's a great deal for insurance companies because it's a lot of value, and in the scheme of cancer treatment, very inexpensive.
So-
I think we got
Oh.
one more question left.
So you said that you bring on this care very early on in the process, and you spend a lot of time getting to know these patients. And sometimes it's years before they actually transition to hospice. So once they do get to that point where they are making that transition to hospice, do you follow them through in hospice? Or if you don't, how do you kind of help them transition onto another care team?
Thank you. Another great question. That process differs among different situations, the way different teams are set up. And it depends if, that team or that palliative doctor or provider is part of their hospice team too. Generally speaking, once hospice is activated, all care is transitioned to that. And it's generally the hospice nurse and their hospice team who assume overall care in that condition. And hospice, often at times, that includes all specialist care. All of that is transferred to the hospice too. So there's communication is possible between the hospice team and the specialist for any specific issues, or say a particular medication adjustment or other different issues that maybe dressings with surgeons or situations like that, where that communication is can still happen once the patient is enrolled in hospice. But generally speaking, all the care will transition to hospice at that time, palliative care included. But it's a very gray area because there can still be a lot of back and forth if there's because understanding every circumstance is different.
And one of the reasons that's done is once they're transitioned to hospice, usually it's the hospice team goes to the home. So it's hard to have a practice where you're seeing patients in the hospital and in the clinic and doing the home visits. So the hospice team generally is on the road during the day, going from home to home to home. I would say that, in my practice, many of my patients, I will continue to follow and do home visits, but I'm not managing the day-to-day, what happens in the homes. I'm primarily providing some psychosocial support to the patient and their families who have been my patient for many, many years. But it's not like I'm going there every day, but I will keep in contact with them and the family, and typically make, depending how long they're in hospice home care, 1 or 2 visits, especially as it gets toward the end of life, and where having a doctor that's been caring for them for years can provide a lot of psychosocial, emotional support, because there's such a relationship that's been built. So,
The nature of the relationship is absolutely the biggest part of that.
yeah. Well, this has been great. The hour is up. We're going to have to bring it to a close. Dr. Karan Soni, palliative medicine specialist at MercyOne Cancer Center. If you know someone that would benefit by watching this, it will be available on demand beginning tomorrow at the MercyOne Cancer Center website, and also at the Above and Beyond Cancer YouTube channel. And if you are watching us live, and you often watch us live, I need to let you know that next week is the Wednesday before Thanksgiving, and we won't be having a live program next week, next Wednesday. Thanks, everyone, for participating and attending, and please join us again next week. Thanks.